Okay, so thanks everyone for joining us today. I apologize for the late start. We had an accident on an iPod coming here, so we got a little delayed. I'm sorry, here in person. I'm just going to do a quick roll call, starting with folks who are on the collaborative and sitting around the table here. So we have Sheila Green-Strook, we have Chad Gavilan, Chris Cable, Cara Towell, our host today, Cheryl Buchala, Representative Joe Schmick, John Scott here, and then to my left is Leah Rosengals, our project managers at UW Telehealth. We have Freddie DeChinko, and Representative Seattle Children's is Sarah Orth. And we'll have time later on in the public comments, and so we'll ask folks to, if you have a comment, to introduce yourself before that. But next I wanted to go to the phone and to video, and I'm just going to call out your phone number, and if you could just identify yourself. So the 206-235-4988 number, please identify yourself.
Hi, Stephanie Cowan with Multicare.
Hi, Stephanie. Are you representing Emily Yu today, or is Emily coming as well?
I believe she's going to be on as well.
Okay. All right, thanks, Stephanie. And then next is 206-987-000 or quadruple zero.
That's probably me. This is Sharon Lindsay from Seattle Children's.
Hi, Sharon.
Hi.
And then 353-3676.
And that's Melanie McAleenan with the Washington State Dental Association.
You said Mallory Macklin?
Melanie, M-E-L-L-A-N-I, McAleenan, M-C-A-L-E-E-N-A-N.
Great. It's great
with
to
the
have
Washington
you.
State Dental Association. Thank you.
Yeah. I don't think we've ever had anyone from representing dentistry, so it's great to have you.
I don't think you have. This is a new thing for us.
Okay, good. So next we have a 206-920-5679.
Hi, that's Sarah Kwiatkowski from Community Health Plan of Washington.
Okay. Hi, Sarah. And next we have a 360 number, 360-280-6142.
Hi, this is Leslie Emmerich, representing the Washington State Hospice and Palliative Care Organization and the Home Care Association of Washington.
Great. Thanks, Leslie. So next we have a 425 number, 918-4000.
That's our number here.
It's okay, okay. All right. And then 503-415-5600. Is that maybe, is that you, Adrienne?
It's Lori, actually, Dr. Scott, Lori Wakashige from Legacy Health.
Okay, great to hear your voice, Lori. And 509-879-7805.
Hi, this is Representative Marcus Riccelli.
Oh, great to hear your voice, and welcome.
Thank you.
Next number is 425-918-4000.
I don't know.
Oh, that's again. Okay, sorry, it's just not moving. All right. And so, anyone else on the phone? I know we have a couple people on video, and I can see you guys. So I'll introduce you, but I just want to make sure we didn't miss anyone on the phone only. Okay, so on video we have Denny Lorden representing Providence in Spokane. We also have Kathleen Damon representing Swedish. I know, Kathleen, you need to leave in about an hour, so we appreciate you joining. We also have John Bose from Labor and Industries. And did I miss, and sorry, Dr. Ricardo Jimenez from CMAR. Good to see you today.
Hi.
All right. Well, first I wanted to formally welcome Representative Buchala, and maybe we'll just give you a brief opportunity to introduce yourself and where you're from, and just a little bit about yourself.
Sure. Thanks so much for having me. And I look forward to in between meetings. So I look forward to joining you guys on video as soon as I can get to a computer and some Wi-Fi. I serve Spokane, the 3rd Legislative District. I sit on the Healthcare Committee, Capital Budget, Transportation, Rules Committee. I'm the House Democrats Majority Whip. I've been very interested in telehealth and worked on a number of bills, including the medical licensure compact, and just look forward to participating.
Great. Thank you so much. And so just for the record, Representative Bergquist rotated off, and Representative Richelli is replacing him. All right. Well, next, what I wanted to do is go to our minutes from last month, and I'm going to pull those up, and folks can review those. And I welcome any comments on that. If there's any bits of that weren't accurate, we'd like to amend for the record.
Well, then I would make a motion to accept the minutes.
Okay, we have a motion. Representative Schmidt has motioned, and Chad second. Any comments, edits? Seeing none, all four, say aye.
Aye.
Any opposed? Okay, great. So will be uploaded to the website and will be available for folks to review. So next on our agenda, let me pull that one up. Was I think we wanted to, I wanted to briefly let folks know about a resource that's available. And so you may have heard about the Northwest Regional Telehealth Resource Center, or NRTRC, which is a service that is available for community health clinics, actually anyone in the state of Washington who has a question, whether it's a policy question, a technical question. The NRTRC is based out of Utah, but they do serve the whole Northwest region. But in addition to that, I learned about this group called OCHEN, and I'm sorry, I don't know what it stands for, but it is a health IT consulting nonprofit based in Portland. And of note, they operate the California Telehealth Network. So just like we have the NRTRC, there's a CTN that covers the whole state of California. Both of them are funded by HRSA, by the Fed, and they are underneath the OCHEN umbrella. So they're a national organization. They serve over 10,000 clinicians, and I think their expertise is in customized technology research and knowledge solutions. They help run PTSO, which is the EMR that NeighborCare and HealthPoint use, two big F2HCs in the King County region. And they are increasingly getting involved helping folks to navigate some of the technical requirements for telehealth. So getting that last mile of coverage is sometimes a real challenge, getting broadband. So they've helped small organizations get over $5 million of FCC grants. And they just kind of partner with them. They also will allow you to do purchasing. They negotiate really good rates. So I just wanted to make sure that people knew about this organization. I talked to them, and I think that they have quite a bit more funding and are a bigger organization than NRTRC. So my suggestion is I'd start with NRTRC if you have a question, and if they just don't know the answer, you could go to OCHEN. But they really do have a focus on safety net organization. So any questions about OCHEN or anything else? Has anyone ever worked with them before or ever heard of them? Chad?
Hey, Dr. Scott, this is Denny. I have had experience working with OCHEN in the California area. It's the Oregon Community Health Information Network, and good organization.
Great.
Are we going to list these as links on our website?
There is a website, yeah, a nice website on
the Telecollaborative website.
As long as folks are okay with that, I mean, I think it's fine since they're a nonprofit and they're in the NRTRC kind of realm. Okay. Well, next on our agenda was I was hoping that Senator Becker was going to be able to join us.
Maybe she's held up on the road.
Do we have Senator Becker? Because I was going to ask her to sketch out a roadmap of the timing and kind of our benchmarks that we need to achieve in order to report back to the legislature on December 1st. But if she's not, maybe we'll move on to the next item. Senator Becker, are you there? Okay, well, hopefully she's not too far down the road here. So let me share my screen and we'll move on to the next item. So I wanted to talk about an idea, and that is around, I think there was a lot of confusion when we were talking about telehealth parity. We're going to dive into now to the discussion about telehealth parity. After me, we'll hear from Brody and Cheryl, and also from Danny Lorden. So I don't know if you guys can see this, but I wanted to walk through the different ways that people get paid, and start off with the situation where there's an in-person visit. And let me blow this up for folks in the room. So starting on this first line, if a patient comes in for an in-person new patient visit and they're either seeing their coverage as commercial or Medicaid, there is both a clinician charge and there may be what's called a facility fee. So the clinician charge is also known as the professional fee. And then a facility fee is incurred if your clinic is attached to a hospital, that's the situation for my clinic, and probably Children's, and maybe Chad at Virginia Mason, you have that. So I just wanted to give you an example of what a charge would be for a new patient level 4 visit. So that's about a 45-minute visit. That professional charge will range anywhere from $150 to $250. And that's I'm just really ballparking it there. If your facility, if you have a facility fee, it can sometimes be almost the same amount. So your total bill might be as high as $500. And if you were being seen in person, same situation, but had Medicare as your coverage, just to give an example of what Medicare now pays for that visit, it's about $131. And they also have a facility fee, okay? So when we're talking about payment parity, I think there was maybe a misunderstanding about pro fees and facility fees, okay? So I'm just gonna stop there and see if folks understand the difference there. So I'm seeing a lot of head nodding here. So then I wanted to dive into telemedicine, and maybe start with the last line and talk about what Medicare covers for a telemedicine visit. So for Medicare, if they were being seen for a new patient visit, and it was 45 minutes, or they had all the physical exam and history elements, it would be the same, $131. And the facility fee is quite a bit less. It maxes at $25. It's a Q3014 code. And that is paid to only one facility. And it's not the facility where the doctor is, it's where the patient is. So we call that the originating site. So if you were just to do a very strict comparison for Medicare patients, the professional fee is the same. The facility fee is quite a bit cheaper for telemedicine. You can just do the math. It might be $150 to $200 for the facility, and it maxes out at $25. So then what I think many of the clinicians and provider groups were proposing in this last bill was that the same professional fee would apply. So so for whatever was being charged for a 99204, if they met all the requirements for their documentation, it would be the same. And then this is where I think maybe there was some confusion, in that we would propose doing the same thing as Medicare, using the same code even, the Q3014, and that there would be at most a $25 fee for just one facility, the originating site. So I'm throwing this out there as a kind of maybe just clear the air, and get people's reactions to a proposal that payment parity would be applied for the pro fees, and that we basically would adhere to federal regulations with Medicare for the facility charge. And now I know that this is what Molina does. They follow this policy, and a lot of the Medicaid providers follow this.
So just, this is Brody. I don't recall exactly what was in the legislation, but is it clear that the parity is related to the professional fee, or is it not?
I don't think so.
Clear?
That was probably,
okay.
yeah.
I don't think it is.
I would just say Ian, the lobbyist who probably dealt the most with this bill, although I am a colleague. I think the word, to your question, Brody, I think the phrase parity was talked about a lot, but there wasn't a definition like this put on it. So I think you have a valid point that we weren't dealing in specific definitions at the time. It was just the concept of parity that was being discussed, which there were some of us in this room who were in a pretty extended discussion about that issue with Senator Becker and others during the legislative session. And I don't even think we got to this level of specificity. We tried to, but it didn't happen. And there were representatives from payers and providers in that discussion.
Yeah. So one other thing I just wanted to point out is that there was legislation that was passed several years ago saying that home was a valid originating site. And in this situation, because they're not in a facility, there would be no facility fee. It would be only one charge, and that's for pro fee. So again, I think that I've heard from the payers a concern about how do we keep costs under control. And what I'm trying to show in this very basic table here is that there is cost savings on the facility charge side of things.
And Dr. Scott, I think you're calling out a point of clarification that we might want to be more specific about what we're calling this.
Yeah.
I think it's typically called an originating site facility fee. I think it's the misconception people have with the typical facility fee. Maybe that will help.
And to follow up on that, maybe I've been misunderstanding it all this time, but I thought the Q3014 code could be charged by any originating site, not just one that's associated with the hospital.
That's correct. So, say Chad has his VM clinic out on Bainbridge Island. That would be a valid clinic site. This is any kind of a clinical operating site, but home, no.
Yeah.
I have a question. Margaret McGinnis from Primera. When you're talking the code Q3014 as the charge for the originating site, that would come in on professional claims, correct? Or are you anticipating it will come in on a facility UB?
It comes under a facility, yeah. So we have separate charges. So when I just know from my own healthcare, when I see my primary care doctor at Roosevelt Clinic, which is a hospital affiliated clinic, I get two separate bills. I get one from UWP and one from UW Medical Center.
When you're a hospital-owned clinic,
yeah.
But if you're a freestanding and not hospital-owned clinic, it's my understanding that the Q code would come in on the professional claim along with the professional.
So I don't know. That's probably getting into the weeds, and I would look to my colleagues around the table on how it comes in. It's not a modifier, though. I just want to make clear that it's not like a GT modifier.
Right. With modifiers on the Q code. I'm a professional coder, so this is where I live. Modifiers.
So technically, I think if I'm understanding the question, so if John were providing a consultation to a patient on what happened, for example,
in a clinic, hospital owned,
not hospital, let's say.
Okay, freestanding.
Yeah,
Nothing to do with the hospital.
Yeah, then you would send the professional fee.
Yeah.
UP would send the professional fee, and that clinic would send the Q3014.
And that would come in on CMS 1500. That would come in on professional. Wouldn't come in on review.
And I agree, it is, we're talking weeds, but I think that's part of the parity definition. We need to make sure we all understand, because it's a little vague at the moment.
So I'm really sorry, because I'm new to the the group here, so please bear with me for just a second. So you're proposing literally that parity is being defined as Medicare rates. That's kind of what I'm hearing. You're not proposing that parity be defined for current insurance or payers rates then. And we would stick with all of the Medicare rates across the board then.
Yeah, I'm just saying methodology, not.
Yeah.
I think methodology.
Okay, methodology. Okay, thank you for clarifying that for me.
Those are different.
So,
Yeah, no, I just wanted to make that distinction. Yeah.
This is Sarah with Seattle Children's. I'm a little concerned about using the Medicare methodology because they don't include things like direct-to-consumer and patient in the home. We have a pilot program right now where our workflow is that a provider on site at our clinic still uses an MA to virtually room the patient and set everything up. So we lose that facility fee and therefore all of the resources that come along with it. So that's something to consider. We're providing the same service. The patient's getting the same service, but we're not getting reimbursed for that. And also Medicare is just dabbling in the remote monitoring space. So what would that look like if you're still using other facility resources that wouldn't be captured with that fee?
Yeah.
So you're saying the eligible facilities, right? We don't want to limit it to just that, like CMS.
Yeah, I think, Sarah, we're probably going to have to take the remote monitoring off the table because there is no stipulation that I know that payers have to pay for remote monitoring at this point.
Just Medicare.
Yeah, just Medicare. Well, Medicare in 2 states, Hawaii and Alaska. So, but I don't know if everyone heard what Sarah was saying. She was just saying that there are some facility fees that are above and beyond $25. That there's some technology, there's staff that are helping them virtually room the patients. Brody, Chris, Cheryl, reactions to this?
I think there's more. There's more than this, just one piece. We did create a discussion document that kind of covers some of these things. Okay. Do you have it to share on the screen?
So,
because I don't think we emailed it out, right, Cheryl?
We didn't email it out. I brought copies.
So I'm just going to turn the floor over to Brody, and they did prepare a document that I'm going to share here a little bit. They had some great questions and points.
And some of them build off of this Medicare type of methodology piece, so I think it's a good segue. So for those of you in the room, there's a document called Reimbursement Parity Discussion Document. Has a blue link on it. I don't think any other ones have it on there, and so we'll just kind of wait for it to be pulled out.
This one, reimbursement parity discussion. Okay. Go ahead.
Right, so just for context, there actually are no proposals in this document as far as positions. It's just as Cheryl, Chris, Francis, who I believe is not in this meeting today, from Molina, and myself, we just kind of met to talk about what are the things that we feel this collaborative needs to cover for us to get to a point where we could actually define what a reimbursement pilot would look like. And so it really falls into 3 kind of major topics. One is defining what reimbursement parity is. You can see that we already entered into that discussion as to what is in, what is out, what does this mean, and what does that mean, and we'll kind of talk about that in a moment. And then the second thing is we actually tried to be a little proactive in the second topic, which was from what we know about our current policies, like what do we feel is going to be impacted? Without even knowing the specifics of what's in the pilot, we feel like these things are already things that we are aware of that would be impacted. And the third topic, which I also hope that all of you value as well, is related to what are the minimum things that we believe need to be a result of this pilot. So one of the examples are, what if the results are inconclusive? Like, what do we do with that as far as, do we move forward with it or not? I mean, it's those types of things. So the third category is like, what needs to come from this study? What needs to be learned from this pilot? What do we do with the findings and things like that? So, because I think it'd be uncomfortable as far as we go through all this work, we end up with really inconclusive findings, and then the decision is, now what do we do about reimbursement parity? I mean, we're kind of in the same boat, right? So just understand what those measures are and things like that. So those are the 3 high-level categories. So do you want me to kind of walk through the?
Let's walk through.
Okay. So as it relates to the first topic, number one, is what is reimbursement parity? I think what we would like to see is a clear statement at the end of exactly what reimbursement parity means to this particular collaborative, so that we can clearly define what the impact is that we need to look at. And so there are some questions that we are posing. Again, there are no positions or statements here. It's really just a discussion guide at this point. Is there clinical parity between virtual and in-person care? And whatever the answer is to that, how does that impact what our definition of reimbursement parity would be? So this is, at this point, just the discussion about clinical quality as it relates from these two. And so I definitely know that the position that everyone holds in this group is that the standard of care is expected to be the same. So we're not saying that we desire a difference in quality. It's just more of a question in practicality. Is there a difference, and does that factor into this discussion? The second item kind of relates very similarly to the difference of the facility fees and the professional fees, is that when it relates to practice expense, is there a difference in practice expense as it relates to virtual care versus in-person care, fully recognizing that there are many physicians that perform telehealth in their office. So that's not to say that doesn't happen, but there are many cases where that is not the case. And so how do we address practice expense from that perspective? And our understanding, I'll speak for myself, you guys can agree or disagree on this, is that our understanding is that Medicare actually pays a different RVU for telehealth when something is billed with a place of service O2 than when something is done in the office. And so I'll talk a little bit about RVUs, and just kind of someone hit me in the back of the head. It was like, no, this is not where we want to go with this conversation. But I pulled out some of the common codes, and in this case, I pulled out like behavioral health, for example. So there are three components to an RVU, right? I mean, let me take a step back. So the fee that is paid, not paid, but the total fee of what is reimbursed is the combination of a conversion factor, and that is multiplied by an RVU, which is a weight. So depending on whether you're removing a mole or doing an E&M, the weight could be different based on what that is. But the conversion factor is generally the same, right? So let's say the conversion factor is $40, $50, $60. Let's say that the weight for that service is 1.0, then you would multiply $50 times 1. There's a reimbursement of $50. So what makes up that RVU weight? There's three components, right? There's the work component, there's the practice expense component, and there's the malpractice insurance component. So the work component is the same, regardless of where you're performing the care. The malpractice is the same, but the practice expense is different depending on whether you're doing this in a facility or whether you're doing this in an office. And so for someone who is billing an O2 place of service, the practice expense is taking the facility portion of the RVU, which is a lower weight than in the non-facility setting. So our understanding of how Medicare works is that even though you could say there's parity in reimbursement, the conversion factor is the same, but it's being multiplied by a different weight than when it's done in the office. And here you could, 90791 is an example of a psychiatric diagnostic evaluation, which I believe would be desired to be in scope in this. And so the weight when done in an office is 3.68. That is the weight. But when done through telehealth, which is with an O2, that the weight is 3.56. So slightly different, but pretty darn close. But there are other services that have a bigger split between the facility and the office. So I think one of our discussion points here is the global topic of practice expense. Does that factor into parity? And then the second part of it is, well, Medicare seems to pay differently with an O2 place of service than when done in the office. So is that considered parity or not? So that's kind of a discussion topic. I know I kind of went into the weeds on that one, but Practice expense is one other factor as we define.
Brody, I just want to make sure folks know what RVU stands for. It's a relative value unit. For the folks who are not in this all the time. It's actually how I, as a doctor, get graded for my clinical productivity. So this is where if you're a proceduralist, you get more RVUs for doing procedures in general than cognitive stuff. We all have benchmarks that we have to have several RVUs. So you get more RVUs the more complex the patient, the more time you spend with them. So that's, and there is indeed a conversion unit. 1.0 RVU equals X dollars. That's a very common metric that we use in medicine. Any other questions before maybe just a good time to pause to see some of the things that that Brady was talking about?
Well, just to tie it, this is Chris Cable with KP. So to tie it to the example you showed earlier, John, I think you were maybe showing just the physician work RVU being equivalent in those two Medicare scenarios. Is that just to make sure we're aligning the two discussions? I believe that's what was crossing over the same.
Yeah.
Well, I think the other question you need to talk about is, are we going to accept the premise that Medicare has established or not?
Right. Yeah.
Yes. I mean, that's the very big, the first question before we move ahead.
Yeah, I mean, in medicine, Medicare has often been the leader. I mean, I think commercial insurance and Medicaid has always followed Medicare, for better or for worse, but there is a strong precedent for following Medicare.
Yeah, so I think where we get into talking about parity is the same conversion factor.
Yeah.
So from a health plan perspective, I think that would be our measure of parity, but it may have a different RVU weight, resulting in a different reimbursement. So I think that's what we need to talk about when we're talking parity. Are we talking the same dollar amount, or are we talking the
same RVU?
Methodology. Yeah.
Yep.
So the outcome may be different, but the methodology may be the same, right? So.
And it might, maybe we can put an example together of what that looks like. So I think it's a complicated concept. I mean, once you kind of get to it, it makes sense, but it's a little bit hard to get to.
Yeah.
Right. And this is an example that I think where I get honestly a little confused, and our own payment policy is a little bit scattered in KP. The different codes you choose will have different RVU values, of course, but there's the same clinical encounter probably would be valid for a couple of different codes. And so that's the part that I think we want to get clear on, is trying to minimize that variability. You could choose an online evaluation code, which I think already probably has the RVUs that are assuming it's an online visit, and so it's got that level of expertise and involvement and engagement, which would match that, versus an E&M with a modifier, which has a totally different outcome for the same RVU conversion factor. So
yeah.
I think that difference is important.
Yeah. So those are two different pieces, just to kind of share with the group. So item number one is, even if a physician bills the same code as what that physician would have done in person, there still is the discussion topic about practice expense, right? So the fact that something can be done in a lower cost brick and mortar setting, does that factor into parity or not? Another, I guess, somewhat related to that is, are we following Medicare or not? Because in reality, if we did, there would be a difference in actual dollars, even though the methodology is the same. And then the second item that is being called out right now is, from a health plan perspective, we have reimbursement policies that provide some level of instruction on what codes to bill. We don't tell you what codes to bill, but it's directionally, saying that this is the reimbursement policy for what codes apply for this service, and those codes may be different than what you would have billed for an in-person service. So I think those are two very important topics, but not the same topic.
Rudy, can we talk about practice expense? Because I think that there's a perception that because we're not using medical assistants, we don't have that bricks and mortar room or whatever, that it's cheaper. And I just know from my own experience that what we replace it with are some pretty expensive pieces of equipment, like a cart, a telemedicine cart. Those range from $10,000 to $20,000, and there's associated software fees. And instead of a stethoscope that I can buy for $100, they're $1,500. So there's equipment for there and that's associated, and then there's people on the back end. It's not your medical assistants, but there are technologists like Adrian, who's helping me today, who's helping with those connections. So I just wanted to make sure that the payers appreciate that, know that it's not the same cost, but there are still other costs that might be potentially recovered in a facility fee.
And Dr. Scott, I just wanted to echo that. We have significant costs in infrastructure and support that facilitate telemedicine visits, and it's hard to quantify based on the program or the application, but they are significant most of the time.
Yeah, I just want to add on to that, Chad, sorry, from Virginia Mason. You know, when you get into those intricacies that you're talking about, you know, there's also the differentiation. Is this a facilitated exam? So you talked about that telescope, or excuse me, stethoscope. Keep saying telehealth. Yeah. No, so I mean, when we level load subspecialists to cover our clinics, we do have a facilitated exam. We have an MA. Whereas if we're out in some of our rural areas, sometimes that's not there, and then we use kind of a differentiated kiosk model. So yeah, I mean, it can be, I would say the majority of time when you're looking at primary care visits, I would almost say that it's consistently more expensive to be doing telehealth visits, and it becomes really more of a patient satisfier or bringing that care to areas that wasn't there before. So I kind of wanted to make sure that we bring that into the discussion.
It's really an access issue.
Yeah, huge.
I would add another facility space issue because we can't use an exam room to do a telehealth visit because that's taking up our in-person exam clinic space and access. We could use a provider office, but a lot of our cognitive-only types of providers use their offices to do visits with patients and families too. So where do we stick these guys who want to do telehealth visits? We can't find a corner in all of the property that we have that's closed off and quiet enough that we can get the lighting right so that we can do the visit.
Yeah, that was Sarah Orth from Seattle Children's, and for those who don't know, the Children's has about 5 clinics around the state where they're doing telemedicine. So there's an exam room in Wenatchee where you know, a cardiologist has seen them, but that's, as you said, space that can't be there for other regular visits. So I think it's pretty complicated when we start talking about the fees and the expenses here. So I don't know if there's an interim resolution. It's just a matter of putting everything out on the table.
So, Scott, this is Ricardo. Adding to the debate here, there's something to consider. Right now we have some tools in EHR like an EM calculator that will help us estimate the level of the visit, 99204, 99215. And that usually requires some sort of a physical examination, putting some body stethoscopes and to listen to the lungs, feel the liver, check if there's a swelling of the legs and so forth. That if you don't have that, you just cannot come up with a 99214, the complexity or the level of the visit. So without saying that it will not equate to the same level of service, what I'm saying is that we almost see the need to come up with different tools to estimate the complexity of the level equivalent to the 99204 that is calculated based on a physical examination. The limitations are pretty clear. I'm not going to be able to do a lung examination, a heart examination, to feel somebody's belly. So that needs to be taken into account. That, I don't see that there is a tool now to replace an EM, the current EM calculator, for instance. So something else needs to be developed to guide us of what the level is going to be. Otherwise, people are going just to be making it up or working it through as it is without a standard agreed tool. Again,
wouldn't you still, pardon me, wouldn't you still code it appropriately based on your consult?
Oh yes, but again, I mean, a 99204, for instance, a 99215, I would be very hard pressed to code that level without putting my stethoscope in somebody's lungs. I'm going to be honest with you, it's not the same. As a clinician, I mean, you can call it whatever that, but the technical aspect, the technology, the equipment, and so forth, cannot replace the personal interaction, the touching, the talking to the patient, the feeling that the patient is this or that. I mean, there's something. And again, I'm not dismissing that the complexity may be high, but the tool to come up with the level needs to be worked out. That is not available to us yet. So that's going to be one argument from the payers, and I can see that. I'm not advocating either one, but that needs to be considered.
Yeah, and I would echo Chad's point that we train telepresenters in how to use digital stethoscopes and things like that and palpate bellies, but obviously they can't do all the things that you're used to doing or might require.
Yeah, and those are exams that are developed and guided by physicians. And so, yes, you may not be able to touch a patient, but certainly if we've trained our folks adequately, these are nurses, healthcare professionals that are delivering expensive healthcare professionals that are delivering this exam. It does add costs. So
I'll just chime in at bullet 1A here was, I think, contributed by me. So I have the same question that I don't know the answer to, but that question around clinical parity, and I think that's part of it, is there's obviously a drop-off from a face-to-face visit in terms of what you can do, what you can see, what you can touch. And so there are some scenarios where you can have a stethoscope and do, but I think for a lot of times you don't have that either. You just have a video screen, or maybe not even that for a forward visit. So I think the answer in my mind is probably yeah, there is some drop-off in clinical assessment. I don't think it's necessarily severe, but if we're using the word parity, that's a high bar in my mind. And is it the same as face-to-face? I think no. Is it worth something? Absolutely. But that's right. I struggle with the parity question versus some relative ratio that feels more aligned with what might be a reasonable change in clinical.
Yeah, perhaps, and I can add that, I can echo that. That's basically what I wanted to transmit. Perhaps we've been boxed into the parity and trying to equate both telemedicine visit with the personal visit. And perhaps we shouldn't have done that at the beginning, just keep an eye, a broad perspective of things and an open mind. Perhaps we can equate it. It doesn't matter, again, from my perspective as a clinician, as a good old family doc, I have a hard time trying to equate both at the same level. Perhaps another option would be to become so efficient in the visit that we are not going to be requiring a 45-minute time, but doing whatever we can do in the context of a telemedicine service, being efficient and compensating the reimbursement with the amount of volume that we can do with the service, rather than trying to use the parity concept, equating it. I'm just suggesting that that's something that we should have entertained at the beginning, and not just being boxed into the parity concept.
Well, maybe if we can wrap this little section up in terms of some follow-up items. It'd be great if we could actually see some examples of RVUs.
I can share these.
That'd be great.
But I think, at some point we're going to have to talk this through and come up with a group, statement.
What is parity?
Yeah.
Is it Medicare policy? Is it is it the letter to the law of Medicare?
Yeah.
Does it include facility fees? I mean, as you can tell, there's a lot of things to consider here.
One last observation, I guess, for me, and this is obviously just my inference. I don't know how Medicare decides that. Sure. But I think because Medicare has rules around it being like Alaska, Hawaii, or designated rural area, that these are places where you have no other choice. And so I think some of the payment parity is driven by not necessarily the assumption that it's clinical equivalent, but it's basically what you have and right access. So I think I wouldn't necessarily presume that it means Medicare agrees it's clinically the same.
We made reference to the needs earlier, and I actually, so what I always try to do is go back to the language that the legislature crafted to give to the collaborative, and I think it's right along the lines of what both Dr. Scott and Brody have led us discussing, right? So the section of this bill that gave the collaborative the task was the collaborative shall review the concept of telemedicine payment parity. I think that's what you all are exactly doing right now, right? it's easy to say the word parity, but even in the example that Dr. Scott gave of what Medicare has kind of led on, it's, you know, it's not the pure definition of parity. There's some recognition in the Medicare policy around facility fee. The payers are rightfully bringing up the concept of, well, what does parity mean within that professional or the clinician fee? So I think this is exactly what the legislature wants you to do, because particularly in a session, and Representative Schmidt will, I think, agree with this, you know, that getting into this minute detail about the concept of the word parity is just not possible. And so they're looking for your all guidance, if it can be agreed upon, about what that could look like. I do think this is important that we've teased out some where the differences or where the disagreement may be on the concept of parity. There's the one that always kind of smacked me in the face was the facility fee, right? Which is recognized in the Medicare policy of, all right, you're not going to be able to charge the same facility fee that you did when it's an in-person visit. They just locked in at the $25 figure. But now, as I hear Brody describe the nuances of the professional fee and the RVU and the practice expense, there's all of those points of potential disagreement, or I don't want to say disagreement, but, you know, varying opinions on what the value should be. There's the RVU itself, there's the weight, but then there's the one that you also touched on, right, which is just the actual rate of reimbursement. Because in Dr. Scott's chart example, right, you had up there, you had commercial Medicaid charge, this is what we'll charge. Of course, there's a recognition that even in an in-person visit, right, the commercial rate is going to be higher, obviously, than that Medicaid rate of reimbursement. And there's that difference level. And as Representative Schmidt and I said to each other, you know, the question is the Medicare rate the right rate? So I don't know if it would be helpful, but I think from this conversation, we could make a list now of those specific points of discussion or debate, or let's just say flat out disagreement, that, you know, the payers might come at it from a perspective of, wait a minute, is that really the same? Is that
Clinically equivalent?
Is it clinically equivalent? Is the practice expenses different? I mean, Brody, I thought your example was a great one of psychiatry. In my mind, actually, I would think that maybe the practice expenses, that's an example of where they would be the least different, because of the type of specialty it is. I would love to hear an example of where probably you've got a much greater maybe variance in what that practice expense might be based on having the patient right in front of you than not.
Dr. Scott?
Yeah, go ahead.
This is Denny. I'm wondering if we might be able to help refocus this by talking about negotiated rates versus RVUs or what Medicare charges. Because I think, and correct me if I'm wrong, most of the time providers will be contracted with payers at a negotiated rate. And that's the in-person rate and what we would hope would be the telehealth rate.
Well, I think we have to be a little bit careful when we start talking about rates, but typically the rates would be a conversion factor, and that would be the negotiated rate times the RVU that's already been predetermined. So the RVU is not a health plan determination, right? But the conversion factor is.
So it sounds like, Cheryl, that the RVU is kind of the coin of the realm, but that's the basic unit from which all negotiations and payments stem from, right?
For the most part. Yeah. I mean, exceptions can be made. You can do things based on charges. I mean, there's different ways, but I would say RVU is the basis for most.
But I think if where he's going is if the negotiated rate for in-person versus telehealth needs to be the same. I mean, it'll be the same conversation as we're having right now, right? Because at the end of the day, the negotiation is, I think the RVU year is fixed, right? But it's the conversion factors that negotiated. But since we follow Medicare, the RVU for a telehealth visit would be lower than the RVU for an in-person visit. because of that practice expense piece. And I think it's important to state that it's not saying there is no practice expense, but the practice expense is different. So in the case of that psychiatric diagnostic evaluation that I just shared, the work RVU was 3.0, that's fixed, right? The malpractice is 0.11. So you add those together, you end up with 3.11 so far. Yeah. And then the difference between the practice expense for a facility is 0.45, while at a non-facility setting, it's 0.57. So that's where that 0.12 comes, and that's why when you add it all together, it's still pretty darn close. But that is the methodology that the plans use. So whether you talk about the actual rate itself or whether it's negotiated rate, I mean, that's the methodology. That's how it kind of shakes out today.
And we'll always have variations in rates, right? And so it matters with whom we're speaking. But I don't know that we should always look to Medicare or Medicaid or whatever versus what we can negotiate.
So just in the spirit of a full discussion, like someone mentioned earlier, the parity being a challenging word or a high bar, I guess in my mind it would have been, we could go back, think about telehealth payment equity. That feels more like what we're trying to get to. I think we'd agree that telehealth payment should reflect some mix of the costs to provide it and also the value to the patient. And those may or may not be exactly the same parity as face-to-face. They're probably actually not. But that's how I kind of think about it, is what's the equitable payment for telehealth rather than matching face-to-face, which starts to have all of these additional questions. I don't know if that's still something we can think about as a more useful term.
But yes, I would agree that, as Ian suggested, if we came up with a really specific list of things to talk through as a group, we could figure out how we could dedicate the time and just kind of hash through it. But I think the main point of today was to highlight some areas, and I think that if we agreed on which areas we wanted to dig into deeper, we've only gotten through 2 of the first 5 so far. You can see that this is obviously going to be an area we'll be discussing, but the first one was really about that kind of clinical quality, whether there's parity there. The second one is about practice expense, whether that factors into this. If I can take 1 or 2 minutes just to kind of read through. I think the rest of the 3 are ones that will require less conversation about it. But the third one here was, if we take a step back from, like, the goal isn't necessarily parity in this case. The goal is a successful telehealth program in this state, right, that people will want to use. And so how does reimbursement parity impact consumer adoption? So there are many clinics, even clinics in this room today, that price their telehealth visits direct to consumer at a lower rate than those that are done in person. And that has nothing to do with health insurance. This is your externally facing price that you set out, recognizing that you may be operating at a loss on that, but that's not the point here. The point here is that there was a reason why clinics priced it lower. And is it because of consumer adoption? Is it because if there wasn't a price differential, would you feel that you would get less people who would actually use that service? And so I think one of the questions here is, in the bigger scheme of the goals, how does consumer adoption factor into this discussion of reimbursement parity? And then the fourth one is related to that, is that I've heard that there was a need to have equal payment so that you could actually recruit more doctors that are willing to do the service. I think that's a really good question as to whether reimbursement parity is the factor that would drive that, or is it more than that? And so the question here is, would reimbursement parity impact provider adoption in any way? And I don't know if there are other ways to study that than actually doing reimbursement parity. There could be a study there. And then the last one, I think, is just kind of this overarching concept of, what is the reach here? We kind of talked about remote monitoring. We talked about, is this patients in a healthcare facility, patients at home? Is this provider-to-provider e-consults? I think parity probably makes less sense there because you're not doing in-person versus that. But, still the concept of synchronous versus asynchronous, like how far does this reach? And so I think the overarching goal here is if we can craft a statement as to what exactly reimbursement parity is, and if we kind of talk through each of these aspects of it, I think we could come up with a pretty good statement that would then, everything kind of just falls into place from there as to, okay, what is the impact on the plan? What codes can we use? It feels like it's too early to start talking about specific CPT codes that are in or out of scope until we can kind of hash this piece out. So again, the proposal is more of a discussion document rather than a position at this point, but anything to add as far as what we want to do?
Well, I think you kind of have to have an idea of what you intend telehealth to do. You know, what is the intention? Is it to avoid a doctor's office call? Is it to avoid urgent care? Is it to emergency room? See, I'm thinking about all this in a rural setting where it's an hour's drive to the hospital, not to the clinic, just to the hospital. I mean, so I guess I'd like, think about this in those areas. What do you want this to accomplish? Because you can design anything you want with the proper incentives to get the behavior you want, you desire. So I just throw that out there. Keep that in mind. You know, what at the end of the day, what do you want? So that we know when we get there, and then you can incentivize something to happen.
Maybe if I can respond to that. I mean,
please.
For me, and I'm speaking for UW-Madison, I really think that telehealth is a tool for us to accomplish the triple aim. So for those of you who don't know, the triple aim is to improve the quality of care, to improve the patient experience, and third is to decrease the average cost. And so that's our holy grail. That's everything that we try to do now at UW-Madison is organized around this idea of the triple aim, and I think it can. I mean, we know for sure it improves the patient experience. We know that for a lot of people, the alternative to telehealth is no care. Is they simply don't show up. They don't drive the 5 hours from Eastern Washington to Seattle for a 15-minute appointment. It's just not a good use of their time and money.
So I think that's good to have.
Yeah.
But like I said, let's have a goal at the end, or at least think of what we want to accomplish.
What do other people think? What do we want to accomplish with those?
I'd love to know the answer to the third one, the affordability.
Yeah.
But I think that's the part that we don't know. I presume that's what the pilot would be about, because there are other studies out there, and it just makes implicit sense. When you make something easier, you get more of it.
Yeah.
And so utilization absolutely goes up with telehealth. I don't think anyone would disagree with that. The question is that outweighed by the benefit? And I think that's what is not really known. So I think that's the part of the triple aim, which is a little uncertain still across the whole population. Certainly there's individual cases. You can say this is a great example of it, but in a population, you can get a lot of usage.
I kind of think that would. Go ahead, Danny.
I was just going to say that in the words of the new health secretary, we need to figure out how to be more efficient and bend the cost curve. We also need to focus on increasing access. We're going back to the provider discussion. We've got a growing shortage of providers that's getting worse and worse. And unless we recruit some of these folks to do telehealth, we're going to have a worse problem than we do now. And then we need to figure out how to get out specialty services where they're, as Representative Schmick mentioned, they're in short supply. So value, we need to focus on value for what we can provide, and really looking at how the cost curve and use telehealth to do that.
Well, I like all of those ideas, but I think we just need to continue to think about these things to focus where we're going. Because I do think that whatever this collaborative comes up with is going to be pretty highly valued in the legislature. That's why they only put, what is it, 6 things in the bill as suggestions to take a look at. So we didn't have the whole broad spectrum. Let's focus on these and see if we can make it work. See if we can derive the value, both for the patient and for all those systems as a whole.
Sure.
Well, our goal is for patients to be able to get the right level of care when and how they need it, and any provider to be able to offer that level of care. And we remove all of the barriers that it takes to get to that. So talking through things like reimbursement and payment and technology and Wi-Fi and infrastructure, all that stuff, we can come together and figure out how to minimize those barriers and make it easier for providers to offer care and patients to receive the care. We look at utilization studies with telehealth. Sure, yes, there are. It depends on how you're measuring utilization, right? So is it just the frequency of the touch points that increase? Are patients getting better acuity level of care? So now they can stay in their home and not drive to the hospital and be admitted to an ICU bed, and now someone who needs that bed can't have it because someone else drove there to get it. So how do we impact all of those things by removing the barriers? And I think that's what this collaborative can do.
Does anyone want to answer the question that Brody raised about, what are patients or consumers? Why are they taking alcohol? Well, I mean, the patients are doing telepsychiatry.
Yeah,
What's the benefit to that?
Access. I mean, that they can get it, convenience, that they can get it without going lower cost for them, so that they don't have to take off time from work and pay for the travel and things like that. So.
I talked to every one of my critical access hospitals, and when there was that pilot program in years past, they all loved it. Every one of them brought that up, said that was successful for them till the people ran out of money and then it stopped. But that was one that came up because I have 6 of them, and every one of them talked about that.
So
I would just like to throw in that not everything is direct online virtual care. When you're talking about a patient in a hospital having a stroke or a patient in the emergency room dealing with mental health issues, it's not like they have a choice. They're there because they have to be, but having access to the providers they need is all that matters.
I was at a recent meeting with Boeing. We had a accountable care organization relationship with Boeing, and for them, the most important thing is productivity. So if you guys have gone to the Everett plant down the road here, they've got 787s that are slowly moving down the assembly line, and if someone needs to go to see a psychiatrist, they're often gone for about 4 or 5 hours. By the time they clock out, get on the car, check in, and maybe it's only 15 or 20 minutes to pick up their prescriptions. So they're looking, to telehealth and say, why can't that person go somewhere in a private room on the factory floor and have a telepsychiatry visit? And so those are the kind of things that we think are of value to patients and their employers, who ultimately are, in between the patients and payers here.
So this is Chad. I'm going to jump in. I'm going to use that psychology model you guys talked about, because we're really trying to hone in at Virginia Mason on a little bit of a different collaborative model. And so, obviously we have Karina, basically, which is a virtual care clinic. Somebody can pay $39.95 or $52 or whatever, and they can see for some very basic ailments, they can see a doctor quickly, and that's very convenient to them. So some cases, some folks are eligible to come in and see a psychiatrist, and they can do that virtually from home or from their office or wherever, and that's really good. But for those complex patients, where it's not just the actual visit, it's the follow-up medication management and all of the coordinated care with social work and stuff like that, that adds the layer of complexity. And so then as I'm trying to put all of this stuff together and think about Brody's concerns and some of your earlier comments, Dr. Cable, I'm going back to the first part where I'm struggling with the Medicare model, because I just don't think that it's going to give us what we're looking for. And to your point, I think we're now using telehealth in such a new and different way, and trying to come up with so many different models that it's really, really hard to define things within kind of the aspects that we've done. And I know you guys are working really hard to kind of blow up some of the traditional models too, so that you could take advantage of that. So, getting back to the original point, I'm sorry I'm taking us there. Do we really need to look at what the visit type itself entails? And I'm starting to think, just hearing everybody's thoughts, that beyond the objectives, we as an organization have limited resources, and gosh darn it, we're trying to get as many ducks in the door as possible. They're just not out there anymore. And then patients, nobody wants to drive in the city of Seattle because they got a cold. So there's competing priorities in all of this. So anyhow, I wanted to throw that out there. I'm hesitant to think that what we want to accomplish and what our patients want to accomplish are always aligned completely. Because sometimes we're filling a gap that we know best about, and sometimes the patients are feeding us what they want the most. So we're still trying to meet those two worlds. Yeah, that's kind of.
I'm interested to hear from some of the providers about how important is parity for providers. Maybe I think I saw Emily Yu from Multicare, or Sarah, or Ricardo. Would you guys be willing to comment about parity when you're talking to providers?
This is Sarah, for those on the phone from Seattle Children's. We have a direct-to-consumer pilot and a lot of providers that want to do it, even though they're going to be operating at a loss because they don't get that facility fee. They really don't care. They say, I'll not bill at all. I'll do this for free. Please let me do it. So we're standing in their way because we can't get them the technology fast enough.
That's amazing.
Right, yeah, this is Emily Yu, and we have currently, two pilots within our primary care clinics to, not only have a dedicated medical group in order to answer video visits, but to try to have the providers integrate this into their normal clinical day as an option for the patients that are established with them and are already seeing them, who may not be able to make it into the clinic. But that is one thing that keeps coming up, where if they're going to take a hit to their clinic finances or even their individual productivity in order to be able to offer video, it is one of the biggest barriers I hear from providers on being able to offer this to their patients.
I think Ricardo, is that you?
Yeah, I think overall our providers are eager to do this. In fact, we are moving ahead on teledermatology. We are implementing as we speak, as well as telepsychiatry. We've been doing that bits and pieces here and there. So provider-wise, it is very well accepted. I don't think we, as clinicians, our clinician group they are not really in tune on reimbursement methodologies, to be honest with you, because of the nature of a community health center. We are looking at access, and the way we see telemedicine, the potential is to enhance what we're already doing, especially target those patients who don't come, non-compliant patients, that we can make interventions through telemedicine that do not require necessarily complete comprehensive visit, not to replace what we do, but to enhance what we are doing. Again, the clinician group is a little bit detached from the reimbursement methodology. But as a CMO, my concern is that we may what I'm interested in finding a sustainable way of implementing solidly these services, because I see the potential. We already, as I said, in teledermatology, the little thing that we're doing, the ECHO project, John, some of our sites are doing hepatitis C, HIV. The potential is amazing. It's incredible. So we can accomplish what we want to do to provide access to our target population. But as an administrator as well, I'm concerned about sustainability in providing the time, the resources, good technology to our providers to do it, so that I can maintain the enthusiasm from our providers. But I don't have any doubt at all that the clinician group sees that the patients are excited when we do telemedicine in a focused way right now. So overall, I see our organization implementing it, perhaps with no clear future on the sustainability, no clear answer on the sustainability, the financial aspect of it, but we are going to be implementing it. That's what I keep on saying. Why don't we find something that is a compromise, not necessarily equating one-to-one, because it will be very hard, not necessarily from our perspective, but from the third party, for the payers. I see that it's going to be a battle, a fight that in itself is going to be a barrier for us to moving ahead and implementing this. I see that reimbursement as a real barrier to implement telemedicine, even if it is on a limited basis. It just pays off. I mean, it exponentially increases access and clinical quality measures on patients that don't come to the clinics.
Thank you, Ricardo. So I'll just share a conversation I had earlier this week with one of our administrators, and this is about maybe the second most common question I get when I talk about telehealth. And Sarah's smiling at it. She knows what it is. What is the ROI? What is the return on our investment? And this is where I say, well, patients like this, and sometimes there are downstream revenues or whatever, but without certainty and payment, it's very hard to give them a hard number. And a lot of times the ROI is not always there. And so we have our feet in two different boats right now. We have our one foot in the fee-for-service world, and then we have our foot in the value-based care world. And I think telehealth is going to really make sense when we go to value-based care, but we're not there yet. And if I can't go to my colleagues and say this is a positive ROI, they're not willing to even do that initial groundwork and to get some experience, so that when we have hundreds of thousands of people under value-based care contracts, we're not going to have that expertise. So that's a real challenge I have. I have a hard time selling this unless I can tell them it's a positive ROI. I'll just be totally frank with you.
Can I respond a little bit to that? This is Marcus Riccelli. One of my interests in joining up here, and I'm the new person, is that in Washington we're the technology state, and moving us from exactly to that point. I mean, it's not the if, it's the when, and not talking about telemedicine, but just this is medicine. And if you look at how I fully believe that from the patient side, we're trying to reduce barriers to access, et cetera, provide opportunities. But the provider resistance, I understand around the reimbursement, but it's real concerning because I did have a chance to attend the American Telehealth Association conference in Chicago. And, at first I had questions like, is it the technology, the barrier? No, it's not that. It's operations. And, so my interest in this group is how do we kind of take what I view as inevitable, where we're headed, and kickstart it in Washington so we're not left in the dust.
So John, a couple ideas. So again, I guess I'll bring up the term of equity versus parity. A couple quick examples from KP. So for our dermatologists who do telederm, I expect them to do about a third more visits per unit time than face-to-face. If I paid them, so to speak, at parity, I guess I'd be overpaying somebody by a third. Yeah. But they do it and they like it, and they actually, to your point, they find it a different thing, right? Anything that's different in your day is kind of nice. So they enjoy doing that. I think part of telehealth value as well is even broadening to the quadruple aim around provider and team sustainability. I think you can get to the place where people can carve out this to do at home even and not have to deal with car crashes on I-5. That's great. So I think there's a lot of value for providers in terms of just variation in your day and maybe ultimately avoiding a half day of commuting at some point. That's kind of the nirvana. The other example I'll give is we internally have a way that we've evaluated what would the equivalent of e-consults as new visits, and through our own data we found that probably a quarter of those were real replacement visits and probably 3/4 were not. So we valued them at a quarter. So for every 4 e-consults you do, we'd say that feels like 1 new visit, and people do them at 1/4 value. So again, for me, it's around in the moment for that individual visit, what's the equity payment for that visit? What's the value? What's the cost? How do we make that fair? And then on a large level, what's the utilization across all of these? How do we understand the costs to all of us as we roll this out? I think those are the 2 parts that I think we should focus on.
Dr. Scott, this is Denny. I just wanted to add a lot of the new applications that we're doing these days are screening patients before they come into clinic, because the providers are already so busy that if we can screen some of these patients or more appropriately treat them at home or in a lower level facility, we can keep those clinic spots open for higher acuity patients, and that's really a value to the provider. And when you supplement some of these follow-up visits with telehealth, you're really creating an efficiency model, and I think that's what we need to do as a health system to do better.
Yeah, I second that sentiment as well. Well, maybe it would be okay if we maybe pause here. I really appreciate this talking points. I think there's some things we need to maybe come back to and refine. and we didn't even get to your topic 2 and 3.
No, I mean, I think those all build off of one, so if we kind of cover that. I mean, the one thing that we didn't put in this set of topics, which was addressed, was it is kind of later on there as to what the role of the clinic administrator is in this whole piece, because I can definitely understand that if physicians' time is being valued based on RVUs, that is definitely an impact, but that doesn't have to be the way that physician time is valued, right? So I don't have a suggestion here other than what is the role of the clinic administration in part of this, because there may be a piece of that as part of the solution for parity as well. That wasn't listed in the first 5, but it's listed later. So.
Well, so then the next thing on our agenda was to talk to Thea Mounts, who's the Office of Financial Management, and she was on our call last time, and she was going to share with us the all claim payers database. I think I kept that right, Thea, and was just going to walk us through what kind of data is in there and how this might be important for this pilot project. Thea, are you on the line?
No.
There you are. You were right here. Great, Thea, you want to come next to me, and I can advance that quick. Yeah. Okay.
Did everyone get copies of the handout, the 2 extra handouts?
Yep,
With
and
the...
it's attached on the email. And
okay, perfect. Okay, and I've got copies of this too. Let me get to that slide. Okay, so thanks for having me to talk about the APCD today. As Dr. Scott said, I'll give you an overview, a little background about the APCD, talk about what's in the database, and then the data request process. Go to the next slide. Some of you may know the original legislation passed in 2014. With that first bill, the data that was in the database was going to be very restricted to just the Medicaid and the public employees benefits data, so not particularly useful beyond maybe some state use cases. So between the 2014 and 2015 legislative session, there was a lot of work done, particularly by Senator Becker, to improve the statute, and so that bill passed in 2015 and allowed us to take in the commercial data from the commercial carriers. It also made some changes to some reporting restrictions that had been in the original bill and directed the Office of Financial Management to procure for a lead organization to run the database. So the purpose of the database, I won't read the bullets up on the screen, but really focused on assisting patients to make better choices, providing data for purchasers to identify value and promote cost and quality in the state. So the implementation of the database began in October 2016 with the signing of the contract for the lead organization. For the implementation, funding for that came from 2 CMS grants, Cycle 3 and Cycle 4. Additional funding from the State Innovation Model Grant to enhance our data collection. And in the statute, we're required to have the APCD be self-sustaining through the sale of data and reports. So that's going to be our challenge moving forward. As I mentioned, I'm from the Office of Financial Management. We're directed with overseeing the APCD implementation. We're developing rules to support the database and do some analyses. We've contracted with Oregon Health and Science University as the lead organization, and they're responsible for the overall management of the database and operations, managing the data vendor contract, doing sales and outreach to support the database, and reporting on the state common measure set. OHSU is subcontracted with On Point Health Data out of Portland, Maine. They're a data vendor. They have a lot of experience in this area. They've implemented about half of the APCs nationally, and they're responsible for actually taking in the data and doing the data aggregation and augmentation. Just a little diagram of what the governance structure looks like. There are also two committees that support the APCD, Data Policy Committee and our Data Release Committee, which is tasked with reviewing requests for data and developing the criteria for the release of the data. Representation on those two committees is comprised of state agency representation, the larger insurance carriers in the state, the Medical Association, and the Hospital Association, as well as a few other organizations. Okay, so the data submission program. Currently, we are taking in submissions from more than 30 carriers in the state, health and dental carriers. The Healthcare Authority is submitting data for the fee-for-service Medicaid population. Labor and Industries will be submitting workers' compensation claims. They were a little bit behind the other submitters because their data look a little different, so they are just working on their first submissions right now. And then with the passage of the bill, the mandated submitters are the fully insured plans. The self-funded plans were not mandated, but they can submit voluntarily. The lines of business that we have in the database, again, include the commercial fully insured, Medicaid fee-for-service, the Medicaid managed care, Medicare Advantage, the PEB, the dental insurance plans, labor and industries, Medicare fee-for-service, we have to acquire through a different process. And we just signed the data use agreement with ResDac out of University of Minnesota that manages that process for CMS. So we should be obtaining the Medicare fee-for-service data here pretty soon.
Can I ask a quick question?
Sure.
Do you get any self-funded claims from any of the payers right now?
Not at this point, only the PEB. We did do some initial outreach with some of the larger employers, and they were wanting to see the value, the values to them before actually submitting. So we'll be reaching out again now that we're about ready to open our doors here for. We've been taking in data since last year, and so the data release, we're going to be July 1. Data requesters are going to be able to have access to the data. Currently, our definition for who is in the database is Washington covered persons, so persons covered by policies issued in Washington. We're in the process of amending that through rule to expand to Washington residents. It's probably mostly an issue for those border cities like Vancouver, Southwest Washington, where people may be living in Washington State and working in Portland, so their coverage is through a plan that's under the Oregon State. And then there's some Medicare Advantage plans that are actually regulated outside of Washington, so we want to make sure we're capturing those as well.
Will this also then apply to self-funded?
That would require a different change because it's specifically called out in the statute that the self-funded are voluntary. So unless.
But this would not change that.
Correct.
Okay.
Right. That would have to be a separate change if that were to happen.
So the question was about self-funded folks, that requires a separate process, right?
Right. So and just to step over to the side there for a minute to describe that. I don't know if some of you may be familiar with the Gobet versus Liberty Mutual Supreme Court ruling from a couple years ago. I think it was the state of New Hampshire, and Liberty Mutual had a case where the state was mandating the self-funded ERISA-covered plan to submit. That went to the Supreme Court, and we're not allowed to mandate the ERISA-covered self-funded. So there are other self-funded that are not ERISA-covered. But in our statute, it's all self-funded currently. So let me just go back to that one for a minute. So we have medical, dental, and prescription drug claims, plus the enrollment records. So we know who has which coverage during which time periods. Data we actually started with January 1, 2013, but the 2013 data are more sparse because of it required the carriers to go back further than 3 years to submit the data, and some of them weren't able to do that. So really January 1, 2014 forward, our last submission was March 31st. And we do collect the data in on a quarterly basis. So within, by the end of the month following the end of a quarter, the submitters must submit their data. And then those data are available for access and use within 6 months of each of those data intakes. So there's some processing time that's required. This is a snapshot of what our 2016 data looks like. We do have the 2017 data in, so I don't have the updated numbers, but we're close to 4 million covered lives. All of the Medicaid, most of the Medicare Advantage, 88%. The commercial market, again, we're a little over half. The discrepancy there is the self-funded that doesn't allow us to get to the 100%. We are increasing the number of covered lives, and of course, with the addition of the Medicare fee-for-service, that'll be another 900,000. In the statute, the legislature was very specific about who could have access to which types of data. So this chart represents the boiling down of what's in the statute by categories of requester. Across the top, there are 6 categories. And I've got paper copies here too, if anyone needs more copy. And then down the side, the brown rows represent whether a confidentiality and/or a data use agreement is needed to access the data. And then the blue rows represent the different types of data that are called out in statute. So the direct patient identifiers, so your name, social security number, date of birth, the proprietary financial information, which is that negotiated rate between the insurance carriers and the providers. Indirect patient identifiers, anything that could be linked with other data to potentially identify patients. The unique identifier is just a research ID that links the records across time and across carriers. So, if someone is, they're on Medicaid and then they get a job and they move to a plan where they're in the commercial market, we do the best that we can to link those identities across time for those longitudinal studies. And then the other data, that includes the procedures and diagnosis codes, as well as some other information. And so if there's a plus in the box, it means that that data level is available to the groupings across the top. So in column A, you have researchers with an IRB approval. They can request any of the data elements. B is federal, state, and local government. They can request any of the data elements except the direct patient identifiers. The 2 middle columns relate to the lead organization, so OHSU. If they're acting on behalf of the state, they can request to use the same level of data access as the state agencies. When they are not acting on behalf of the state, they are not allowed to have the proprietary financial information, as well as they cannot access the direct patient identifiers.
So can you give some examples of like who's wanting it and what they use it for?
Okay.
I mean, I see these things that.
Okay, sure, yeah. So we've had a number of requests from the state agencies, and so those have been working their way through the request process. So, for instance, the Department of Health is interested in looking at the long-acting reproductive control of the LARC devices to see the usage. That's one. We're at OFM, where I work, we're interested in looking at access. So as well as having the patient information, we have master provider index, so we're able to see where providers are practicing. So looking to see where, if there are areas of the state where maybe there aren't particular types of specialists seeing Medicaid patients or, some other specialties.
And what have they been doing until now?
To get the data?
Yeah.
I think some of them haven't had access. Some have made use of the state's Medicaid data, so it's limited just to that population.
So the Telehealth Collaborative, would we be considered column E, agencies, research, and other entities through the league organization?
Well, I think if whatever, goes to the legislature, if the legislature passes something that has you using APCD data, I believe that would allow you to have the access that they're granting through if there's legislation.
So it has to be an act of legislation.
Well, that would allow you to have it without going through the request process. If it's the request process, I guess, you're sort of a mix of organizations represented, so I guess it would be E unless there's, I don't know if you have any government representatives.
We have Labor and Industries, John Lewis is on this group.
Okay, so depending on how you structure the request and who's doing the work, I guess you might be able to.
With Representative Count.
I guess if he has a bill or something, yeah. So those would be different ways for the collaborative to access the data.
And so then it sounds like we would still need to find someone to do the analytics, right?
Right.
So they have the data, but they're not.
Well, or possibly OnPoint has an analytics shop as well as OHSU. So depending on where you want it done, if there's something that they could do on your behalf, that's one route. Or if one of the organizations represented by the collaborative is able to do that work, that would be another route. Next slide. And then just talking a little bit about some of the data products, we will have some very high-level rolled-up public use files that really deal more with that common measure set reporting that will be available on our website. The website's going live on Friday, so that'll be out there. And then the fee-based products, as I mentioned before, we have to be self-sustaining, so there has to be a way to pay for any of the work that gets done. Or if people are wanting extracts, data extracts, those have to be paid for. Next slide. And again, so we do have a couple of products. So data extracts. We also have established a cloud-based analytic enclave that has, it will have 3 data files in it that are de-identified. One is a safe harbor, and then there are 2 limited data sets. And with the enclave, the data plus analytic tools are in the enclave, so R and SQL are in there for the analyst to go in and actually analyze the data in the enclave. And again, the standard reporting or reports, ad hoc analytics, those are also available for those organizations that don't have analytic capacity in-house. On Friday, as I mentioned, on the website, we'll have the data request page. So on there will be the application for request, the data draft template for the data use agreement, data management plan for those who actually are interested in getting an extract and having the data in-house. You have to go through the data management plan with timelines, and the data release committee reviews any request that has proprietary health information or proprietary financial information. And with any request, our goal is to release the minimum data set necessary to complete the work. So we're not wanting to hand out data left and right. We don't want people coming to us and saying, okay, we want everything. It's really what is it you need to use this for, and identifying those variables that are necessary. So just a quick look at our timeline. Friday is the the big date, and then going forward, there are just some updates that will happen with the website. Just a quick peek at our website, the Washington Healthcare Compare. This is really, a lot of it's focused towards consumers and providing them the opportunity to identify practices and locations for procedures and for provider practices through cost and quality metrics.
Like sort of the Catholic?
No, we've done this ourselves. Yeah. And just an update on what's on the website. And then the public accountability piece are the common measure set that the Healthcare Authority has established.
How will people know about this to go out and do comparisons?
We are getting the media, sending out press release. There'll be some information on the governor's Medium site that we hope will get picked up. And then just through some of our own stakeholder channels, we're releasing the information and my contact information if you have any questions or questions now, things that I've missed, information that would help clarify.
Danny, go ahead.
Dr. Scott, I'm wondering what your thoughts might be about possibly utilizing this to look at payer compliance with our original parity law. I think we talked about the fact that we sent out a letter to all the payers asking them for their billing and coding policies, and we got 2 responses back, and we're not sure that there's very good compliance, and it might be an opportunity for some more education to talk about what the current law is. Maybe we could pull, GT modifiers and look at denial rates or denial codes or whatever, try and get a better understanding of where we sit.
I guess I had a question for Thea. I just want to clarify, do we have to pay for this?
Yes.
Okay, all right. How much is it?
Yeah. Well, it's not cheap. It depends on the request. Yeah, it's
ballpark.
Well, it's hard to say. It's hard to say.
Because that is one of the things that we demanded, is that it be self-sustaining.
Right, right. So, if you're interested in finding out a little bit more, we would probably have to scope out some of the parameters to get an estimate. I don't want to throw out a number without
So Jenny,
having some information back from you.
We don't have a whole lot of money.
But doesn't the legislation actually reference the all payer?
It does.
As part of the study.
Mm-hmm. It does, $63.99.
Yeah. We were going to use it.
Right.
Okay.
So
but you're taking
that part
information.
needs to pay for it too. Not just Jenny's side request, but anything related to this pilot would have to pay the database.
Right. Unless there was I don't know if there was a fiscal note attached.
There was not.
There was not.
But
Okay.
the policy bill references accessing the all-payer claims database. Funny enough,
We'll be in touch.
Okay.
Perfect understanding.
Okay. Any other questions?
Thank you for coming.
And if you think of anything else, just send me an email.
Seems like it's a really powerful data set. 4 million claims.
It is, and so we hope to have, as I mentioned, the first requesters will have access to the data starting in mid-July. So hopefully, my hope is by session to have at least some probably simpler analyses available to demonstrate the value come session.
All right. Well, we have about 10 minutes left. Denny, I had put you tentatively to talk about the certificate requirement. I think we talked about that previously. Would you mind if we talk about that next time?
Not a problem.
Okay, thank you. I know you prepared for that. What I wanted to do next is talk about our next meeting. Because I don't think we have that scheduled, and I would like to propose that we do it in the eastern part of our state, since it's been a while. And looks like Representative Schmecker is so great about traveling here all the time. I'd like to see if we can explore our next meeting in the summer in the Spokane area. I know that, Danny, you've been very kind to host us before, but I don't know if there's opportunities to either have it at offices of Representative Schmick or Representative Riccelli, or possibly even Jeff Jones, who's in Newport and is on this collaborative. So I'm just going to throw out if anyone from Eastern Washington would be willing to host us.
Who else do you have from Eastern Washington collaborative?
So Danny Lorden, Dr. Jeff Jones, who's in Newport, and then Representative Riccelli and yourself. Four.
I mean, I was going to say, I'm sure Representative Schmick and I could come up with an idea of figure out a way to host.
Okay.
I'd be happy to help coordinate a location.
Okay. And I'm thinking about sometime in August. From the legislative calendar, do you have anything then? When do things start ramping up in the legislature?
Well, just get past the primary.
Okay. When is the primary?
First Tuesday of August.
First Tuesday of August. Okay. All right. So your preference is to do it afterwards. Okay.
Or say that's 7th.
Okay. 7th. August 7th.
So anytime after that.
Okay. Would it be okay if I send around some dates that I can get out and
sure.
I'll try to pull others before we. But we're probably looking towards the last 2 weeks of August. With have it in Eastern Washington. Great. So next I want to open up for public comment. And first, if I can see if there's anyone here in the room who would like to speak, ask a question, comment on anything that was discussed. Please tell us your name and where you're from. Okay. Not seeing anyone raising hands. Anyone on the phone? Folks from the Dental Association, Palliative Care, other groups, please chime in right now.
This is Sean Ackerman from Emery Group.
Hi, Sean.
Hello. Sorry I joined the call a little late, but I just listened a little bit about the parity discussion. And, you know, I just want to put in our perspective from a Medicaid point around parity. And, you know, I think a lot of the conversations that went around, you know, the differences and the difficulties in trying to find out what is actual parity in terms of RVUs versus in-person visit on telehealth. I think it's good to have those conversations, but as we get in more and more advanced in technology, I think we are going to see a little bit differences in the comparisons in in-person visits versus telehealth. And I think these discussions are just going to get harder as we bring in other, for example, wearable equipment and more advanced remote monitoring. So from our perspective, we have been advocates of promoting telehealth so that providers are utilizing it and really incorporating into their day-to-day practice. And as payers, we like to remove reimbursement as a barrier. We feel that if there's going to be, you know, new discussions around what this payment should be, really put this in the court of the providers and saying what type of reimbursement model is going to make you utilize this tool, because we want the adoption rate to increase. We've had products here that we rolled out for providers and patients, and you know, with very poor utilization. And these services actually been free for both sides. It just you know, we are not in a position to really micromanage and look at, you know, if the utilizations have increased slightly by a slight RVU changes. We're looking at more of a population health point of view of the overall value of telehealth. As more and more providers use it, you know, the overall cost of the healthcare system will be reduced. So I would really direct these conversations towards how the providers will be willing to use it and how the adoption rate is going to be. Because in the long term, as we're moving more towards value-based purchasing, we feel like telehealth will really not be in the conversation of parity, but more as an extra tool where providers will be using in a more of a capitated model, saying, do your best in keeping your patient population healthy out of the hospital. These are all the equipment and technology under this agreed upon rate or this capitated rate. I think that's where the future of this is going. But in the meantime, I would really, really ask the providers, what will it take for you to use telehealth? It could be even more than, paying for in-person visits when you're doing the comparison. So that's our perspective in telehealth and promotion of use in the community.
Yeah, thank you. Appreciate those comments, John. Other folks on the line who would like to chime in? And I also want to invite folks on the collaborative like Lori Wakashi or Sheila who haven't had an opportunity to speak. Feel free to chime in now. All right. Any other comments? Well, great. I think we'll end a little bit early. Thank you, everyone, for attending. We'll be uploading the minutes from last month, and we'll be in the next week. We'll finalize our next meeting, but tentatively the last 2 weeks of August in Eastern Washington, and look forward to rich discussion next time. Thanks, everyone.
Thank you.
Thank you.
Thank you.